Hello to everyone. This is Dr. Scott MacLean, and we're going to be having a webinar tonight. And the webinar is going to be taking us on a little bit of a journey. And what I'd like to do first is to talk about a concept, to tell you a little bit about myself, probably one of the newest partners with Dental Corp. And it's something that I'm very proud of, and we're just in the final 12th hour of getting everything all done, which is not a good time for everyone, but it's one of these things that happens. And so anyway, the talk I'm going to talk about is about digital technology, but this is what I want to do. When people used to go out and do these big trees, what they would do is go out, and this metaphor came from Dr. Clayton Davis. And Dr. Davis said that when they go out, they would cut down these big trees, and then in between, what they would do is sharpen their saw. And I like that kind of metaphor, because the metaphor really is talking about what we're doing now is sharpening our saw, getting ready for the patients, getting ready to come back and do things in a new way. To tell you a little bit about myself, I do have a Instagram account at Dr. Scott MacLean. I love to meet up with any of the Dental Corp partners and talk with you, shop talk. Also YouTube channel that can help you with implant stuff, different things. So there's about 3.7 million views there, so take it in. I'd also like to thank a few people, like for instance, the Mr. Graham Rosenberg, and also Guy Amini, and also Nate Caplia. So these people have enabled me to come and talk to you today. I love the kind of core values that Dental Corp stands for, and we'll be talking about those a little bit later. So as I said, the first thing we want to talk about is about the digital workflow. And then the second part, I want to spend about 10, maybe 15 minutes on cash flow challenge. And what I'm going to share with you are some of the things we do in our own office to kind of deal with that, because really there's going to be something coming at us that we've never seen before. So I want to share some kind of concepts and ideas about that. So the digital workflow is something I've been playing around with for quite a while. And there's a number of steps, and this is like a checklist. And I remember I do a lot of traveling, and I have done a lot of traveling. And I remember one time I was flying back home, and we came in just to do kind of a landing and a runway landing. And all of a sudden, the pilot at the last second kind of pulled out of it. And when he pulled out of it, he pulled up. I didn't know what happened. And he said he didn't have his checklist. And so what that meant was he didn't have the landing gear down. I heard the landing gear go down later. So checklists are very important to keep people on track. And so it was one of the scariest days I've flown. I flew actually on a flight just before the crash that came in one snowy night as well. So anyway, it's good to be home doing a Zoom meeting. It's a lot safer. We're going to talk a little bit about how we take the patient from collecting data and planning and doing a surgical template and making temporaries, and then go into surgical delivery and restorative delivery, and then finally into a maintenance phase. And so these things can all be done in kind of a checklist fashion. And when you see it, you go, okay, yeah, I can do that. This is something that we can kind of make happen. So what happens when we bring a patient is we're going to start to do some diagnosis, some data collecting. We're going to do perio records, medical exams. We're going to do kind of restorative exams, look at what's going on, also check their airways, check them for caries, check them for any kind of disease, because we're putting one implant in. But I have this 8-step protocol that I take doctors through that shows them what you need to do when you're kind of planning this. So this 8-step plan, we did it actually earlier on a webinar, and it's a good way, and we can maybe come back and do that at another time. So my first step is I want to design a provisional. So I do this digitally. I'm going to show you a little bit about how I do that. But this provisional fits on some adjacent teeth, allows me to kind of organize this and have it done before the patient comes in. So this is all done digitally, milled. So I don't have a mill in my own office. I do have a printer, but this is milled at the lab, and then they prepare this and enable me to be ready for the patient visit. Especially now with digital, it's going to be lowering infection rates as well. Think about it. If you have the temporary already prefabricated, you're not going to have to send it off to the lab back and forth. So digital scanning means that the virus can't go through that scan. It can't travel on the same path. So if we look at this, we're going to then produce a template. And I do 100% guided surgery in my office. I do a lot of implants, and we do a lot of crowns and a lot of full mouth reconstructions and a lot of things that I love to do. I think it's just fabulous and so much fun. And we work with a number of doctors, and where I would help them to learn how to restore and do the different things that they need to do. So it's kind of working as a group, and I'm part of the Seattle Study Club, and it's a lot to do with how that functions and works. So producing this, we can then place the implant to a depth and angulation and position in an ideal spot. So planning digitally gets that to be done. So if we look at the implant surgery, and we can say, okay, we can place this implant, get that to a position, then also make the temporary, the provisional, at the same time. So the drills are all lined up. We can go in with the first drill and actually feel what it feels like to go in. And I'm kind of assessing. It's like me putting my foot in bath water. I can say, okay, is it hot, cold, or what's going on? And then I come in on the second drill. I wouldn't go as far in because the bone was a little soft, so I can go in and not go so far. So when I do that, I'm going to make it so I can expand the bone a little bit and get my stability. So if I can get 35 Newton stability, then I can put a provisional on. So this is all done in the same day, and it's fantastic the way we can do this. So this is the surgical restorative phase, and we'll kind of dive into these a little bit. So my goal is to get some type of restorative phase done. And I like to have restorative phases that make sense to me, and I use a lot of this angulated screw channel because I'm positioning my implant. If you take a line and draw it right straight down the top of the implant, then you can see that when we do that, that this implant would actually be positioned so that it's going to come out the incisal edge. But then we can kind of tip the screw channel and make it get into the position where we want this to be from good function. And if we look on the other side, we can see that, on this side, that the on one abutment is a single use, it's not a single use, but it's an abutment, one time concept. So what that means is you're putting the abutment on and you're causing this to stay in place. You put a sterile implant in, you put a sterile abutment on, and then you're working at tissue level. So here's a case that I did not too long ago, and you can see that actually it's a number of years ago now, it starts to go fast. What I like about this is you see that the implant crown in position 2-1 is in a position so that I can have the lingual be just like the other tooth, just like the, 1-1. I've been in the States too much, I guess. So I was going to call it number 8. But so the 1-1 is an implant, the 2-1 is a natural tooth. And when we look at this, the lingual aspect is all zirconia here, so no porcelain on this. And what happens is this makes it really strong on the lingual, but it also means that the patient's not going to have this big bump in there. So when the implant is positioned to come out the incisal edge, we tip the channel so it's going to come inside. So it's the best of both worlds. And we'll show you how that works. So our goal is to produce this surgical template plus more, which means the provisional. And so then we can get into surgery. So we want to go across here in this kind of step fashion. So here's the things that I like to get from my computerization. So first, the model. You can see that's actually my own teeth on there. I need a crown on my 3.7, a few teeth there. And anyway, you can see these are STL files. And people get all kind of, okay, I don't want to talk about STL files. They're kind of confusing. An STL file is just a surface file. So it's a file that makes it so that when we go to do something, we can plan on the STL file. And we'll talk a little bit more as we go along. But the STL file is the building block. It's like if you're going to do digital photography. If you did digital photography, we're very used to now having a JPEG. And so a JPEG or a GIF or, these different files. And that's the same kind of concept as the files that we use. They're files that replace the kind of concept of having a cast or a model. So the analog first step is what really a lot of people still do. I know I've traveled a lot and people, about 5% do the digital. And now we're getting more and more and more get into getting away from the analog first step. So analog first step means that you're actually going to go analog, but most people are going to go digital. And the reality is once you send that to most labs are taking it digital now. So they're trying to get digital fast. So on the impression analog, I still use some impression material. Love Impergum. We also have some polyvinyl, so different polyvinyls. So when I'm doing a combo treatment of crown and implant, I might use that. And you can see that as we go through that, sometimes I'm using it to go into PVS. But the goal is to get to STL files as quick as possible because of accuracy issues. So looking at these files, these are STL files. So they're basic surface files. So they look hollow when you turn them over. They look underneath, there's nothing there. And they're usually a single kind of color. So when we look at these two files, that's kind of what is a commodity now. People sell these. So when we do something, we can, print these off as well. We can design on them, change them, cut teeth, do a whole bunch of different things to them. So one of the ways we can get these is to use a lab bench scanner, and then the other way to get them is the intraoral scanner. So most people, this is how you're going to get these files, is by having one of these two scanning mechanisms. So either scan at the lab or scan in your office, in the patient chair. And so when we do this, you have to say, well, why would I do one over the other? So if we're doing an analog impression and then we make a gypsum cast and we put it in a box and send it to the lab and we get this all together, the lab can scan this. So they can take an articulator, put it into the scanner. And I have this scanner in my office. We're fortunate to have a lab technician who works directly with me in my office. He's kind of off-site, but he's in and out of our office and he works kind of for us. So when we have this, we're fortunate because he can take it and put it in here. But why would I do that? So the question is, when do you do it more? And so, but I still do that. So when do I do it? When I'm doing a full arch bridge. So here's a bridge that I placed some implants, and you can see that we placed 5 implants. When we're doing 5 implants, then according to the literature that I follow, then I need to do a kind of a benchtop scan. So a benchtop scan is going to make it so that I'm able to capture these images in less scans. So it may take less than 1,000 scans, where it could be like 2,000 to 3,000 little scans, and I'll talk about that in a second. But there's some evidence to show that when you're doing this, it's best to take that scan on a kind of a benchtop scanner. For instance, the comparison of 3-dimensional accuracy of digital conventional implant impressions shows that if you're doing a digital scan for a bridge like this, the number of implants and the distance between them makes the distortion factor go up. So why is that? Like, what's going on? And the studies kind of show that sometimes we do still have to use things like Impergum to kind of pick these up, send it to the benchtop scanner, and then do a benchtop scan. So they looked at number of implants and how far in between the implants, and what they did was they found that it does make a difference. So we're just not there yet. And some people say, yeah, we're there. If you do an extraoral scan, so a scan where you put scan flags on your implants and scan that, I think that's fully acceptable. But that's almost like a benchtop scanner. So that's kind of cool to look at, and we'll talk about maybe that in the future too. So looking at these, the data, what they found is that the further they are apart and the more implants there are, then the more the distortion factor plays a role. So this is when I would still use my polyether. So I put some Impergum in, take impressions, verify that. And verification is really important. If you don't know about verifications, learn about verification. We don't have enough time to go into that today. But the distance is shown in red versus the distance shown in black is different. So this more space causes more inaccuracies according to the literature. So what happens is when we go across with a scanner, we're taking 1,500 to 3,000 stitched images. And so we're taking actual kind of images, and as they go along, you hear this kind of clicking action a lot of the time. The camera's taking images and stitching them together. So you start on one side, and as you go around, you're actually causing this kind of image to kind of make of the whole bridge. So when we're doing this, there's what's called a Z factor or Z factor, depending where you are. And so the Z or Z factor, when you get from one side to the other, can be off on the scan, especially with the tissues. And so people are trying to work around this, and I do believe that someone will work on this and get this all figured out. But they need to determine exactly the accuracy. So 1 in 5 will be the most difficult for scanning because of the angulation and distance as well. Is as you take the scanner and tip the scanner, if something is tipped, then the scan is not going to be as accurate. So we have to kind of think about those factors when we're doing it. So analog impression is probably a good idea here still. So I'd splint these together and do an analog impression. So this is called stabilizing wire. We cut it into small pieces, then use some flowable, and then put this on top. And you can see that when we do this, we're able to have it so that we can do a nice impression that's kind of stable. This is intended to make something that's going to be a passive fitting bridge. So we want passivity. If we don't have passivity, what that means is that when you put the bridge on these implants, when you put the final bridge in, we want it to be passive fit. So there's no tension on the screws, no tension on the implants, there's no rotational forces when you tighten it down, because you can have issues that can kind of show up. So you need to have this verified with an analog impression and then scan that. So verification is a very important thing. The Sheffield test, where you put a screw on one side and you make sure everything else fits with an x-ray. So you want to verify that the fit is good before you're doing this kind of stuff. So you take your polyether impression with some nice long pins and then get that done. So is it accurate? Digital scanning. Absolutely. The accuracy is there. Look at this. This compares 2 scans that I took. So in fact, the same dental hygienist took these scans. So when someone comes in, we'll do a scan for, say, a digital workup for an implant. So what happened on the left? This was done many years ago, and so they did PVS impression, and then they sent it to the lab, and the lab did a scan. Then on the right, the same hygienist, dental hygienist, what she did was she took an intraoral scan of the dental office and sent that in. And interesting enough, I realized I had 2 Stl files for the same patient at different times and with different formats that we didn't even, kind of look at. But if I look at these 2 Stl files, there's quite a difference. And you can see that on this side, we have a problem with some pull. And so no one likes that. Most dentists can work around that, and get a good impression. But pull sometimes happens, especially if you're trying to do this yourself. And you can see on the digital side, so the analog digital, so the left was an impression that was taken with, say, PVS. So PVS impression sent to the lab and they scanned it. Or on the right, it was an intraoral scan. And it's quite a difference in how that looks on accuracy right here. So if we look at the other side, look at the detail. So it's a pretty wonderful technology. And if you're not doing it, it's really kind of cool. You can also see little things like the occlusion is so well picked up versus little kind of flaps, or what I call it, blebs. You can see one right here. Okay, this occlusal interference can cause your whole case to be off if you're trying to plan a case and have that seat properly. So we want these things to go out of our life. We don't want them to be there, not scrape them off later. This could be a spot that's going to be really important for our articulation. So when we're doing this, we sometimes will do an analog impression and go to the Cavo LS3 scanner or whatever scanner they're using at the lab. I happen to be showing this because I work with this company to do some lecturing. They're not providing any kind of money or anything for me to do this lecture. I'm doing this because I want to kind of share, meet everyone, and kind of learn about what's going on in Dental Corp. So would love to kind of have someone reach back out to me after this and kind of discuss things. I know quite a few of you from some things I did with Dental Corp with fishing trips and stuff like that, and I'll talk about that after. So looking at the digital workflow, so going digital early. So analog early, digital early. What we do is we're going to get a digital impression and take that in with something like a Medit i500 scanner. We'll show some scanners and I'll talk about different scanners. But taking the intraoral scanner, we have a scan done either by benchtop or a scan done by intraoral. And when we do that and do the scan, our goal is to have this so that we're getting into the digital workflow as early as possible with as much accuracy as possible. So when we do that, we can see that the scan is acquired, and then we may even throw in a CBCT scan. So digital x-ray, so we have a CBCT scanner. We'll take an x-ray that goes around the head like a pan and get that x-ray of a DICOM file, and I know everyone knows what that is. If you don't, email me and I'll spend more time with you. So you can see on the implant records that we're taking, we want those two files. So the beauty of this is we have a file that's going to show us through the bone, and we also have an STL file that's going to be allowing us to fit something on top of that file to be very accurate when we put it in the mouth. So then what do we do with this? We put them together. So we start to go into a software. So my lab uses this, and we can see that it goes in and starts to put the two files together so we can start to plan where the nerves are, where the implants are going to go, and then find out exactly where the nerve is to stay away from the nerve with the implants, but to put these in a restorative base position. What does that mean? It means that we're putting this into a position that the restorative doctor is going to love. Patient's going to love too. We're going to put the implant platform depths at the proper distance to make it so food traps go away, to make it so the strength increases, to make it so that this is a well-founded structure. We're building something for long term here. So then our goal is to produce this. So we want to produce this by local lab, or by going to a centralized lab, or by going to a printer. We have a printer in our office, and we'd like to buy another one. So the printers are different, and we'll talk about printers as well very quickly, but I usually get into this in way more depth than just this quick talk. But you can see when we're producing, our goal is to either produce a plan, like I may send it to my X-Guide and do my X-guided surgery. And we can't talk a lot about that tonight, but that's a way for me to do dynamic surgery, guided surgery, but I do the same workup and the same plan, and I get out the other side, I can place the implant into a really accurate position. Or we can do a temp shell, which we talked a little bit about, so making the temporary, so that can shape the tissues. At the time of implant placement, we're getting the tissues to either stay or to be shaped. And then last, the template plan, which is a static guided plan, and we kind of looked at that a little bit. So the printers, just quickly, they're all based on accuracy. So X and Y accuracy and Z or Z accuracy. And the accuracy, so the smaller the number, the more accurate it is. So an SLA printer, which is the Formlabs 2, versus a DLP printer, which are all the other printers. The DLP printers are going to be faster because they're like stamping, and when they're doing a light, they're stamping the light. Instead, the SLA printer, so it's too much information, TMI for tonight, but basically when you buy one of these, you're going to be buying for speed and accuracy. And so the accuracy is important. So let's have a look here and say, where are we? What happened here? And so we're going to go back. We were going to produce this surgical template and more. And now we're going back. So we're going to go back to the start and have a look at this closer. So we're going to do what we call implant workup. So everyone on my team knows what an implant workup is. It means we're taking records. We need to know, do they have perio? Do they have any kind of problem with sleep apnea? Do they have a problem with missing teeth, other missing teeth? Do they have a problem of other fractured teeth? There are a whole bunch of things we have to look at, and that's part of the 8-step protocol. So going to the implant workup, we can see that we're looking at 3 things: depth, angulation, and position. These are the 3 critical factors to understand when you're placing an implant, and it's really super important. And so I would love to have all these scanners. I'm kind of a scanaholic, I guess you'd call it, but you can't keep buying stuff, especially now with the COVID crisis. So, but all these implant or intraoral scanners are fabulous. Some of them are black and white. Some of them have powder. Probably they're not going to make it. Others have, that are USB. Others are carts. Carts, sometimes when you're moving from room to room, you have to reboot them. Some of those issues come into play. Not a big issue, but some issues. Love some of the softwares that you use after. So they all have different factors. Some have flashing lights that do all kinds of stuff. So you kind of have to look at and spend a little time with all these scanners. And I usually do that on other, on a more in-depth basis. But basically the main thing you're looking at here are CART versus USB. That's the main kind of factors. So if you have computers all over your office, or if you have a laptop, you can move around, or you have different things, but it depends on what you want to scan and what you want to do when you're done. Because if your workflow is ortho, then you might want to pick something that's more appropriate for ortho. If your workflow is implant surgery, then you may want to pick something else. If your workflow is perio, if your workflow is whatever, but it depends on TMJ, you want to look at the one that's going to work with your workflow. So see, these are some of the key features to kind of look at. We can look at accuracy and speed, screen, interface, camera size, powder-free, cart versus USB, cost, training and support, subscriptions. All these things demand more time than we have tonight. But what do you think is the #1 factor? It's like if you're flying in an airplane, what do you think is the #1 factor? Do you think it's because you have hot coffee, or do you think it's because you have a comfortable seat? No, it's accuracy and safety. So safety is a really important thing if you're in an airplane. If it looks good, it doesn't really matter. So here we go. We're going to look at this. Accuracy and speed is what we want. So the goal is to kind of look at this, and we can see as we go around, each scanner has a scan path. You learn the scan path, and as you're going through the scan path, you're going to follow the teeth, and you can see what's happening, what's going on. And so as we go through the top and arch and the bottom arch, so here's the scanner on the right. You can see we're doing a model, so or cast. So as you go around, you're doing a number of scans, put them together, and this allows you to fabricate this intraoral scan. So here's what we're going to do with the patient. When they come in, we're going to go CPCT scan and then the iOS scan. And we get these two scans. These are our main fundamentals. After we verify that the patient's healthy, good, everything's good for implants, and we're happy, then we go back in and get the CBCT scan. We're looking at airways with that too. We're looking at a whole bunch of different things that we can't dive down into as well. But the intraoral scan is really fundamentally important to me at this point. I want to go digital early on this. It makes it more accurate. So the digital planning that happens is we get these two files. So that DICOM file, and then we have that STL file. And these are going to be put together. So it's like apple pie and ice cream. You can tell that I need to go and get groceries or something. My wife is bringing home too much salad now, so I'm not able to go and get anything. She won't let me go to the grocery store. But when we're putting these files together, then we put the files together, then we can start to do the plan. And putting those two files together, the programs do this, and there's all kinds of different programs to do that. But we want to see prosthetics first, and then place the implants second. So doing this, I'm looking for what's called a Zenith Reference. So this is a term I came up with. It's a three-dimensional term. So when I take the zenith, which is the high point of the gingiva, and measure in from that, I'm taking this reference line. And this is going to be my reference line for how deep the implant's going to be. So when I'm doing a single implant, which is called an FP1 implant of regular height, then what I'm going to do is draw a line tangential to here. Wish we had more time. We could spend a little bit more drill down time on this. But when we get this positioned, we're going to take the implant platform depth to that position. We want to be parallel with the facial wall, with the buccal plate. So you can see the yellow line is telling me what the angle of the buccal plate should be, and there's a safety space around that. So I want that buccal plate to be safe, and I want this to be at the right depth. So we're getting some implant position, and then we can also get this. You see on the left, the white crown. See how the implant is coming out through the incisal edge of the crown? And this is coming right through. It's a 3.75 by 13 millimeter implant. Well, we can put on an abutment and then correct that. So this is the beauty of this system, is you can come in and change the system so that you can bring the channel right where you want the channel and keep the lingual aspect of the crown very thin. So depth, angulation, and position, these are critical to do this. So when we're looking at this, we can look at the depth, angulation, and position based on the Zenith reference, the pink dot, the yellow line, and you can see as we go in, the depth of this is 3 millimeters. So it's not from the pink dot to the yellow dot. So let me see if I can draw this. I don't know if you can see. Yeah, so it's not right in here. I hope you can see that, but that little spot needs to come from the yellow dot to the yellow dot, not from the pink dot to the yellow dot. And on the, in between the roots on the right, we can see that, oh, sorry, I want to show you this red line. This shows that the incisal edge. I like to plan my implants a lot of the time to get the incisal edge, then tip the channel. I like that in the anterior, especially canine to canine. So if we look at this, we can keep this lingual aspect on the green arrow thin. That's my goal, is to keep it thin in here, but really strong. So looking at this case, we're between roots now. So this is angulation and position. And we can see that we're staying in between the roots. So the yellow line marks the safety factor of the bone. So I have more than I need. So underneath the white arrows, there's more bone here than what I really need. I could make a wider implant if the buccal lingual aspect of this implant were good. So these are the new commodities or consumables that we buy from labs. So we can make these to be fabricated so that we can place the implant to correct depth, angulation, and position, and also get that guided tissue. So we're doing everything. So then our goal comes across. I want to make sure that I'm staying on time, and I am. So we can see that as we go into the next phase of treatment, which would be implant surgery, we've got what we need. We've done the plan. So our goal then is to take this so that we can get this patient. So this is Mark. Mark has a deciduous tooth. We want to get rid of this tooth. Not get rid of it, but we want to fix it. And so as we fix it, we can see that it's not a very long tooth. In fact, for it to stay for someone who's 42, it's been done pretty good. So Mark is allowing us to do an implant. So we place this to the correct depth, angulation, and position with the template. So I could do this with my X guide as well. That's another topic as well. There's so many topics that we could talk about. So when we do this, that's giving me the depth and angulation from the top of that screw. As we change these little rings, we get to the next depth and position as we go in. So most cases are very straightforward when we do this, but like endodontics, there's S-curves, you get problems. So you have to know when you have your S-curve of implants. So that's one of the things I like to train doctors to do, is to find out what implants you should not touch, because there's some implants that some people can do, and there's some implants that you shouldn't do. And so you need to know when that happens. So as we go through, our goal is to get the implant in position. So if we look at this, we're going to attach this little device, and that's to make it so that we can angle the implant. So as we screw this on the back of the implant, this carrier is going to take, and I always call it the wrong name. I know I just did now, but I can't come up and think about the name tonight. But when I take that implant and carry it to the mouth, and I'm going to position that into the template, and then put that and screw it home. So this puts it about 9 millimeters from the top of the template. And so when I position this, it gets it exactly to where it was on my plan. So this is called a mount. Came to me after a second. So this implant mount, you can see the top is spinning. This is 9 millimeters from the ring. So this, when it goes in, then I can put this in, and then I'm going to be certain I'm in a position that is very accurate to be exactly like the position that I planned on my guided surgery plan. So really cool, huh? It's very cool. I love this stuff. It's kind of makes my life, it's kind of puts me in that zone where you feel good about what you're doing. It feels like there's no sweat on my brow. I'm not also worried. I'm on the opposite side. I'm a lefty. So I'm not taking my neck and turning my neck in an awkward position trying to see where I'm going. It's fabulous surgery. So this is something I actually designed. Bone mills, I didn't create that, but I created the shape of this bone mill. So the bone mill that's going to be used here will cut the top of the bone, so I don't even have to flap this on this case. So it's like doing surgery on the belly button. When we do the surgery on the belly button, no, not me, but I don't want to do that. But they go in, they do laparoscopic surgery. They're making the surgery so it's less invasive. So this is less invasive here. Sometimes we have to flap it and look at everything, but if I can keep the flap down and keep it attached, then I will. But I want to preserve also soft tissue. There's keratinized tissue there, and I'm going to flap to preserve the keratinized tissue. So it has to depend on the particular case. So if I try the temp shell in, And you can see I put this into position now. The color is picked by the computer. You can see that the tissue looks greater on the top. The zenith on both sides is looking really fantastic here. So this makes it so that the patient loves to have this rather than having a temporary partial. So it's quality of life at the time of treatment rather than waiting and coming back later, by having a temporary partial. People don't want temporary partials. So this bone shaper tool, it's called CC Bone Mill. What happens is we put a guide into the implant. So the guide goes in, and then the shaper, or the CC Bone Mill, comes down and bottoms out right there. So you can see that it bottoms on top of this, so it protects the implant. And then it cuts the bone to a shape that's going to be perfect for us to put on our immediate temporary. So it's a really kind of cool thing, and I designed that on the back of a napkin, actually, and then they made it. I don't make any money with that, but it's kind of cool to say I came up with a concept or idea. But anyway, so we put the temporary on, and you can see the zenith here. The zenith is marked in that pink dot. I'm all about planning from that zenith. So we pick up the cylinder, and we start to put that into position, and you can see that we're going to fill this in. And we can go over that sometime too. So as we put flowable in, we can kind of pick this up. So you have a PMMA temporary, provisional. We pick it up and we make sure that we're not down on top of the implant. We protect that. And so that flowable and the mill PMMA go together. And when we put that together, we can pick it up and make this beautiful temporary really quick. So it takes about 8 minutes to do that. And that flowable is kind of the critical part. Got a double slide in there somehow, late night. So looking at this, when I take it off after 3 months, check this out. Look at the biological membrane that's sealing this off. So it's kind of like, I use the example, it's like you having a Ziploc bag. We want to seal the tissues. People talk a lot about periimplantitis. This is the key to trying to minimizing periimplantitis, in my opinion. What happens is we want to have like 2 bags. If I take cheese, put it one in this Ziploc bag and one in this Ziploc bag, and I leave this one open a little bit, and I close this one. Well, we know there's going to be mold in this one earlier than this one. Well, the same for the body. Not that mold goes in there, bacteria goes in there. If you're diabetic, it's going to have more issues for healing. If you're smoking, this zone has more issues for healing. So we have to protect that zone, and there's a lot of things coming out which deal with muco-integration. So having abutments that have a special surface to try to make the surface even more protective, because we want to get that zenith be at the point where we're protecting that tissue. So looking at this, can you notice that you can see where it's been bleeding, where it's not bleeding? That's the zone where I tell my patients that I don't want them flossing below this. That's the zone of attachment right there. So I go into that a lot on different courses, but I want them only to floss about 1 millimeter below the tissue because I don't want them to floss in the junctional epithelium. So we want to stay away from that. So we put on this ELO scan body, and the ELO scan body is going to be able to be used by either an intraoral scanner, again, or the lab bench scanner. So they can take a cast and put these on the cast, or we can put them on the patient's mouth, and we can scan this, and we get this lab CAD/CAM software. We can make it so that we can end up milling something either at a local mill, centralized mill, or doing something printed in the office. And I know you're kind of drinking a little bit out of a fire hose right now, but just stay with me because we're going to make this make some sense. Because when we do this, we want to produce beautiful crowns that are going to last long term, or bridges, or whatever you're going to make, printed models. So the digital workflow for doing something restorative, if you don't do surgery, this would be your workflow. It's really simple and fast. It's so fantastic. There's no virus coming through this. Think about it. When we scan on the top and come through, the virus is not going through the digital format. So the earlier we can be digital. So here's how it works. We get this ELO scan body, place it on the implant. Then we're going to do a scan sequence. Scan the lower arch, upper arch, and scan the occlusal record. This is my dental assistant that does that. My dental assistant takes care of those scans. I'm not having coffee. I don't drink coffee, but I don't have time for coffee. What my goal is to be seeing patients. So if I look at this, I'll take the temp shell off. When I come in, she's not allowed to do the temp shell, and I'll scan the emergence. Then I'll take a scan of the ELO scan flag. So those are mini scans. The first 3 scans, which take the time, where the mini scans are the ones I do. So I come in and try to do the rock star stuff, right? So it's kind of fun to do that. So here's the scan. I'm coming in. She's already erased part of the scan, and I'm going to fill the part in when I come back in. So what I'll do is come in with the scanner, position it over top. So take the temp shell off, and then scan just the soft tissues. By doing this, I'm keeping reference to the teeth so that the slumping is not going to happen to the tissue. So we have everything else referenced to that area, and we're just doing the last kind of couple scans just to do that. So we just rock it back and forth. It takes 2 seconds. And then I'll come back in and put on my ELO scan body and do that scan. So it's kind of cool. It's very quick and super easy. Not a lot of problems from an infection control point. There's not a lot of any kind of aerosols flying around here. It's really a low priority, level 3 mask rather than N95. N95 is probably how much they're going to cost, like $95 the way they're going. It's kind of crazy. But anyway, and you can't get them. So we put on the ELO scan body. You can see how it's angled to the facial. So this is not really a big deal because we're going to make an angulated screw channel. So we'll tighten this down with a special screwdriver that comes with the ELO scan body. It doesn't come with it, but you buy it for that. You can see that it looks like it's close to the tooth. It's not. It's just the angle of the implant. In the canine area, it's hard to get a good straight x-ray because the x-ray is rigid and you can't put it in on the angle. So if we look at this, we scan the ELO scan body now. And so as I scan this, this is a super mini quick scan. It allows me to get the position of the implant. So once we get that, we do kind of a look at it on the screen. So you can see that there's the tissues. We can start to pick the shade. That's done from the computer as well. So the shade is picked from the other canine. So I can come in here and click on it and say, what's the shade of that canine? Because the contralateral canine tells me a lot of information about what I want to make on the other side. So that's going to be a 1M2, which is a good base shade. We'll check that with going through. And you can see that when we do this, our goal is then to get into some type of software in the lab. So here we're using DTX Studio Lab. And so as we just check the occlusion, I'm looking at this. I want to get group function on the 3, 4, 5. So when we do this, excuse me, that he doesn't quite have it yet. He's got some protrusive issues here still. So we look at this and we share this back and forth, and I can see what's going on and what he's trying to do. So here we want him to drop down the canine either on the top or on the bottom so we can get group function on the 4 and the 5. And so that I can make a new abutment. Now see, he also has cut away the facial aspect of that implant crown, so he can add porcelain to make this really look nice. So sometimes in the aesthetic zone, we'd add some porcelain like we did here. Do cutbacks, but he can check this and make sure that it's working well. So he gets his crown now made, the angulated screw channels there. You can use special screwdrivers called OmniGrip screwdrivers to put this in place. So I love this kind of abutment, and there's a number of features why. I just want to show you that, and I think we're working out on time perfectly here. So we can see that right here, this is zirconia. So the zirconia core is very strong. It actually has space on this one for lots of porcelain. So you can make this highly aesthetic. When we add the porcelain to it, we can see that on the second one, it blends in, but we can keep the zirconia above it, but the porcelain adds in and is very beautiful. When we look at the third one, we can see the incisal edge can be cut back by itself. You can have full contour zirconia if you want. You can just do facial porcelain, but you can do cutouts and then add little pieces of porcelain to make it look kind of see-through in this area, which is kind of cool too. Or in this area, you leave the zirconia. The body loves zirconia. The body loves titanium. So both those things, as it goes through the tissues, the more the body likes it, the less inflammation. So we also think about this aspect being thinner. So there's not porcelain that's going to chip off. It's just solid zirconia in here. And so my technician's done a great job. Mike has really, really done a beautiful job here. Last is this titanium interface. So that's been fit in a conical connection, like 2 styrofoam cups going together. It fits very accurate, so from the same manufacturer, and make it fit properly. So it's very cool that way. So when we get Mark and get his crown on, we can see we can make it look nice and get it to the right level. And we talk about that in other courses, how deep should this be and where this should be positioned, but it's a pretty good result. There's always things that I like to do when I do crowns and do things like that, but it's not bad. I think it's pretty good. And if we look at him at 1 year follow-up, we can see that he's got, it looks pretty good. The light wasn't really good on this, so you can't really see the proper colors here, but you can see it looks pretty good. Maybe I can tell a little bit that something's going on, but the soft tissue looks super nice compared to what it is. And the most important thing is he likes it. And so we've built it like an elevator cable, so it's going to be stronger than what's needed. We have group function on the 4 and the 5. We make sure that the 6 doesn't have any kind of group function, but we're trying to protect that. Now, I'm going to spend my last 10 minutes hopefully here and keep on time. We're going to talk about the business challenge that's approaching us. This is called the cash flow crisis. So this phases concept was compliments of a friend of mine, Dr. Wael Garin. But I've taken it and jazzed it up and made it my own. So here we go. This red line represents the cash flow in your business, in my business, whoever's business. It was going around. We were actually probably somewhat complacent. You know, we were sitting in our offices and just taking the cash flow, trying to work hard, but you maybe weren't pushing that as hard as you could, but you're pushing it and trying to work hard. All of a sudden the pandemic hits. In comes the virus. You know, this air virus, not bloodborne. I'd rather have a bloodborne virus than an airborne virus. March 17th, shut down by my government. So emergency only. We don't want to have people going into the dental offices. So we could do emergency. So we had a little bit of cash flow, but the cash flow dropped right down on March 17th. And so I said, oh, this might be a couple weeks. It should be okay. So that point right there then started to go even deeper. So emergencies were shut down for me. So the COVID-19 office closure, reduced infection rate, government mandated shutdown, complete shutdown. So we go to zero cash flow. So our net cash flow is, you know, like we're in a negative position. We're kind of at a point where the cash is not coming in. So as we look at this point, we need to find out when this point is. When are we kind of coming back to work? Because in this zone, now the overhead is much bigger compared to how much cash is coming in. So what we would do, we furloughed staff. We, you know, did try to collect the AR. You might have a loan that comes from the government to get your cash up, but this is kind of the crisis for Canadian people. And so the goal was to flatten the curve, but my goal as a dental office owner was to protect the business long term. Same with Dental Corp. So that to protect the business long term, we need to shut it down. We're mandated to do that, but we have to be concerned about the cash flow. So looking at this, where are we going to go? If we flatten the curve, everyone's talking about that. So the purple curve we don't want, the green curve is what we want. If we look at this, what we are doing this all for, just I know everyone probably knows this, is the medical capacity. How many ventilators do we have? We have 380 ventilators in Nova Scotia. Okay, so staff and beds, how many do we have? It's all about how many, because that medical capacity, if we can keep it so it's below this, then the number of ventilators for your province is going to be, you know, set to that. But it's also tapering off. You see the lines dropping down because staff are getting tired, infected, and they're having problems, and they start to drop off. So we did social distancing, cleaning, everything. My wife is going around cleaning, you know, making me move my feet around the house. I should be probably doing more in the cleaning. I'm doing a lot of webinars and stuff like that. But so I'm helping out more. I'm getting some jobs done. But I realized though that, you know, Rick Mercer said, if I haven't cleaned the basement by now, I don't think I ever will. Think about that. If you haven't cleaned your basement and you had a month off, then it's probably going to stay like that for a long time. So we need a vaccine or antibody test or a COVID test to do this. And so looking at this, we can see this is the point that I want to know. When is my office going to open? When can I go back? I'm getting sick of sitting at home. So looking at this, when can we reopen? Government's going to decide that. So what can I think about that? I'll talk about that. Curve flattens to control the spread. How much notice am I going to have? What do I need? How much PPE can I get my hands on? Where are those N95 masks? Do I have to buy them on the market, or what am I going to have to do? So looking at this, if we look at the are not. So this is a very important concept for everyone to really understand and talk to your patients about, because they gain trust in you. You need them to trust you about this issue now. So the infectious period, the longer the infection period, the more likely it is to spread. This has a long infection period. The contact rate, the disease is more likely to spread quickly if no one has the disease. So since no one had the COVID-19, it spreads much quicker because there's no antibodies trying to fight this. And then it spreads through air, whereas the AIDS virus spreads through blood. So the mode of transmission is through air. So hands and air and face, it spreads much faster. So that's the R naught. So when you're flattening the curve, you're reducing the R naught. And so that's what we're trying to do. But it's also flattening our curve on the economic curve. So if we look at this CNN business report, we can see that if we're looking at the shape of recovery, if it's a V shape, fantastic, but it's not going to be a V shape. It's going to be probably more like a U shape, and we don't want the L shape. We want to push things. So what will the economy look like when we come back is the kind of critical factor. So the messaging for you to the patient, we have to say dental offices were closed by government to remove people moving around. Not that we can't handle infections. We've been very good at handling infections over the 30 years I've been practicing. Like, we've been outstanding, really. I've never seen someone come back and say, I've caught a virus from what you're doing, but we have to realize there's new things that we have to adapt to now with the aerosolization. So we've been very safe. We've had all this stuff, but we do need some more training, and we're going to have to keep up with what the government's going to, put upon us. So say it's May 15th, who knows? We need to start, the messages are going to be very patient-centered. For instance, we're here for you. How are you? Any changes in your health? In other words, did you have COVID? How about your family? Any dental problems? What's happening with you? Are you okay? Not, I'm worried about myself getting infected. That's not a good message. It's like, we have to be strong. So our goal is to get this phase 2, which is the recovery phase. And hopefully I'll be done here in a second. But this recovery phase is getting that cash flow back up as fast as possible. So we need to increase the patient visits and then multiply that time production per visit. So we need to get things that are going to be cash flow rich at first, is, try to pick some things that are going to bring our cash flow, things that are sitting on the shelf that need to go into the patient's mouth that we needed to put in. They're already paid for. Collections, we need to collect. We need to get that cash flow back. And of course, we can also push up to the dotted line, but we might take a slower rate, but how we get to that point is up to our team. So this negative cash flow, we need to get into a positive cash flow position as fast as possible. So things that are going to help us, vaccines and antivirals, antibody testing, risk isolation. So for instance, if someone who's older that has high risk, they may need to stay home more, but we'll see how this all plays out. There's going to be a plan that comes out, and we have to wait for the plan to come out on each provincial level and see what's happening. But Dental Corp has been fantastic, helping me even understand some of this stuff. So looking at this line, can we get this line up faster along here? It's going to be the line that I need to do. But think about this. If it was May 15th, we went back to work. I don't know. Government decides that. The economic recovery is going to also play a role. How much disposable income, how much insurance-based dentistry we can do. But this is a strategic plan area. This is an active area that we need to kind of focus on. We cannot be passive at this point. We cannot be passive and sit back and say, okay, I wish someone would call me now because I'm sitting here and nobody's calling. So this is like an airplane taking off. It takes the most energy of the whole flight on that first aspect of flying. If they don't get the energy here, you're crashing. So that's really important for you to understand. That first part is really critical for you to be organized with your team to say, okay, let's get this job done. So phase 3 is this fight and flight, not fight or flight, but we need to fight and fly. And so here we're going to get to the overhead not being as much of an issue, so we get to positive cash. So this is about leadership in your office at this point. And I know everyone's leaders within this organization. It's getting back to your principles. So it's like when you're flying, if you're a bunch of Canadian geese, the one at the front flies and they honk and honk, honk for that geese or goose, goose. And so the leadership is like this. When that one gets tired, you move to the back and the rest keep honking. So your office has to be kind of like that, honking along and making things go. because we want the leadership to increase so the overhead decreases. That's the goal, is to keep someone going to the front, someone keep leading and making this so it happens in your office. So the leadership comes back to those kind of issues of integrity, innovation, collaboration, and excellence. And so those are the things that we have to kind of focus on, these core pillars that Dental Corp has given to you. And so it's time to kind of tap into those, because it's going to be about getting that overhead to be less than what your cash flow. It's going to be, the overhead needs to be taken over as we start to take off. So just a couple more minutes here. Please just give me a couple more. And you can see that when we do this, there's going to be a number of things that we can do, like limit purchasing. Also reducing hours at first and getting the staff to really understand how that works in the cash flow business. We showed our team how the cash flow works. They don't understand that. What they understand is that they come to work and they get paid and go home. And if it's not busy, they don't understand that that can put stress on the office. So it's about that dental team understanding this, and it's keeping them informed. So they need to know that they're an important part of your team. They're furloughed. They're not fired. They're not laid off. They're furloughed, and furloughed is very different. It's a temporary kind of aspect. So what we've done in our office is try to have team meetings. This is not my team, but we have team meetings that we can do. So I call them Zoom coffee breaks. If I call it a meeting, then they deserve to be paid there. We can't do that right now. We have to kind of be in a protective mechanism. And we also have a WhatsApp group that I've created. So the WhatsApp group, I can get things quickly out to people, whether they have an iPhone or an Android phone. I can get it out to them, get messages out that are private, it's secure, and make that happen. So it's all about getting that done. And I just want to jump ahead a couple slides here because I don't have enough time to do those ones. But I have a couple things that I want to say just as I finish here. And we need an action plan, or what we're going to do. People are going to be freaked out. They're going to come into, you're coming into their social distance. So we need to know that they're going to be safe. We need to know that they have cash flow problems themselves. We need all hands on deck. We need to sit down with their teams and say, let's celebrate when we get some patient in. Let's high five when we get the patient in. Not high five, I can't do that anymore. Maybe do a kind of a toe cake or something. But whatever it takes, people on the team need to do whatever it takes here. There's not like you can do your job and I can do my job. We need to share the jobs and trust our staff now more than ever. Not getting mad because you're upset or you're anxious. You need to trust your staff and establish a core message that's going to be safety, health, and immune system improvements for improving quality of life. So figuring out your core business, making sure that you're discussing all their concerns and talking about their changes in their medical history, how they feel, what's going on, talking about them, not about your crisis. It's about their crisis. So with that, I think I'm on time. I'd like to thank Dental Corp. They've been very good to me. You can see there's my first trip with Nate and with a whole bunch of really fantastic doctors that I got to meet. And I can honestly say I didn't meet one person that I didn't like. And it's one of the reasons that I'm kind of involved with this company now, because I think it's a fabulous way to kind of be doing dentistry. And I think it's going to be incredible.